Great, thanks, Jeremy. Yeah, thanks for the opportunity to present, and welcome to everyone on the call. My apologies to start with. I had kind of lost track of when my slot was, and then only realized yesterday's. So what I've done is I have updated a talk and updated quite an old talk of mine, but I did go looking for some more recent information, and the vast majority of what the old talk contained seems still to be valid. It's a talk that some people may have heard, but I think it's still worthwhile listening to. And I think many people who've heard my talks before know that I do sometimes try to kind of challenge established wisdom and things like that. And that's really prompted me to look at fever, because it's one of the things that obviously we all encounter very, very often. But I think we also have got some things to learn about it. And hopefully everyone will kind of leave today's session at least having learned something new, or had their existing knowledge reinforced to a large extent. This talk is intended to be quite interactive, so Jeremy's going to be popping up some polls along the way. But please, as he mentioned, please do put things in the chat. And it's not that long a talk, so I really am hoping there'll be quite a lot of time for discussion both along the way and at the end. It is a kind of a little bit more light-hearted than many of our other Monday afternoon talks, and maybe a little bit esoteric. And as you'll see as I go through the slides, a lot of what we're covering here is going to be things that you will be able to use at the bedside on a regular basis, but some of it's kind of more I don't know, things that I find interesting, and I'm hoping you will find interesting too. It is initially aimed at an audience predominantly after children, but I think it translates kind of quite well also into a more mixed audience. But yeah, please do. People have got other relevant information that doesn't apply to the pediatric setting. Please do bring that up as we go along. Okay, so let's start. So first, as I say, it is an updated version of an old presentation, and I do want this to be as interactive as possible. So very much, please do go ahead and respond to the polls and put messages into the chat. That really is my intention around how this should run. It's not intended to be comprehensive, so I'm not pretending I've covered it in a huge amount of detail. And I'm sure, as I say, that many of the people on the call will have additional insights to provide, and that's exactly how I want it to be. So to start with, and we can have that first poll coming up now, Jeremy, is the first few slides are really just kind of establishing where everyone is and what your thinking is and how much variability there is around approaches to kind of clinical scenarios, but also just a whole bunch of day-to-day situations. So the first one is, what would you do? The patient that you're being asked to look after is a 1-year-old child who presents fairly run-of-the-mill sort of presenting complaint. They've got a cough, coryza, a blocked nose, runny nose for the last few days, and their measured temperature is 38.5 degrees. And how this works when I've got a kind of smaller audience, everyone has to choose, and if you don't choose, then you automatically get option E. Please, I can see there are now 146 people on the call. Obviously, some of us are presenters and moderators and things like that, so I'm not expecting there necessarily 140 responses, but if we can get somewhere close to that, that would really be great. And the options are paracetamol, ibuprofen, tepid sponging, antibiotics, and as I say, if you don't respond, then you automatically get option E, which is resector hypothalamus to deal with the elevated temperature. And again, when these were first put together, I did want people to have the option, if they wanted to, of being able to choose more than one of those options if they did. As the poll stands right now, you are only able to choose one. So just choose the one you think is most relevant, acknowledging that it may well be that more than one might be relevant to this particular scenario. So I think, Jeremy, you can close the poll. We've got almost 100 responses. That's excellent. I hope that is what continues, and the vast majority of people have gone with giving paracetamol. Few giving ibuprofen, not small number, almost 20% who are going with tepid sponging as the most important option, and so that leaves about 50 people who referring her to neurosurgery for hypothalamic resection. Anyway, just joking about that. Okay, next one is exactly the same scenario. It's just now an adult. So an adult presents with same elevated temperature, same clinical presentation, and you've got exactly the same options there. And please do go ahead and respond. We'll just give people a bit of time to do so. I can see the responses coming in, which is great. We're up to 50 already, which is good.
Gary, I think this one should allow more than one option, but I can't see it quite from my side, but hopefully for the audience, they can choose more than one if they want.
Okay, I also can't tell, but if people do have an option to choose more than one, if it's allowing you to do so, please do go ahead and choose that. Thanks, Jeremy. Okay, Jeremy, you can close if you want. We are over 100 responses already. This is outstanding. I've never seen this many people responding to the poll. And the responses here are fairly similar. Close to 90% are going with paracetamol, slightly higher proportion of people going with ibuprofen than went in the previous one with a child, and a little bit of support, much less so for tepid sponging antibiotics. And we actually do have 2 people who have taken option E seriously, which if you want to put up your hand and tell us why you want to do that, please go ahead. But I guess that may be mistakes in what people have submitted. Okay, so let's go on to the next one. And this takes us back to the original scenario that we had. All I've done now is change the height of the fever. So instead of it being 38.5, it's now 41.5. And the question is exactly the same. And yeah, please do go ahead and respond to the poll. Going well, we've passed 50. Slowing down, but yes, they're still coming in. Okay, we've got to 100. So I think each time we get to 100, maybe we can take that as the end of the poll. So Jeremy can probably close that one now also. And as you can probably see there, here we have a slightly different set of responses. If you think back to what we had on the first one, still close to 90% of people going with paracetamol. Here we have additional support, and I can definitely see now that people are able to choose more than one option. So thanks, Jeremy, for that. So presumably some people are going with a combination of paracetamol and ibuprofen. Much greater proportion of people, almost half of the respondents are including tepid sponging now. And we have 20% of people who are going with antibiotics, presumably with one or more of the other options. Okay, very interesting. And to be honest, not that different to when I've run this poll before with other audiences. And you'll be interested to know that, I don't know about the majority, but probably close to the majority are getting most of the questions wrong, at least by my interpretation of the correct approach to it. And we'll come back to that. Okay, so just some thoughts, and maybe we can pop in your responses too, because I haven't got polls for this. Unless Jimmy, you have an option of putting up a free text poll, but I think it's easier just to put into the chat. So exactly the same situation. You've got a febrile child, fairly minor upper respiratory tract symptomatology, and the fast asleep. Someone measures their temperature, and it is high, and they have been unwell. Would that change anything? So maybe if people one or two people want to type, that's great. If not, then you want to put your hand up.
Maybe
I don't know, Jeremy, would that work for you?
I can do a true pulse poll if you'd like, Gary. Hold on, not this one. If that, so we can say, would it change? Sorry. I see what you're saying. That wouldn't work for true false.
Maybe just if there are one or two people who are keen to get involved in the discussion and they want to put their hand up and contribute. Otherwise, I'll just leave it here for people to think about, and we'll come back to it at the end. Okay, I'm not seeing any hands. Okay, so that's fine. So, as I say, we'll come back to that. What if the child is awake now, but they don't look particularly sick? They've got the same presenting history, the same temperature, but are we going to be running after them to hold them down and give them medication, or do the tepid sponging, or give them the antibiotics? Or do we think that this in some way changes our approach to their care? And again, if there's someone who wants to pop up a hand, please do feel free to go ahead. But in the absence of that, maybe just think about it, and we'll come back to the end. One person said let them play, but that wasn't the question. The question was whether they're going to be changing their management. We've got a suggestion to give them intravenous paracetamol. And I must be honest, I actually haven't included the intravenous versus oral versus rectal discussion in this talk, and maybe we can come to that at the end, because I think it is an important part of this, and one I think links back to what I was saying at the beginning, is that we often might not be appropriate in the care we provide. So thank you for highlighting it. We'll come back to that. What if they're teething? So now they don't have the blocked nose and the running nose or the cough, they've got the fever, and their mom says that they're teething. Does that change our approach to the management? What if they have a family history of febrile seizures? Would we do anything different in that regard? And the last question for us to think about on this slide, what if they've had previous febrile seizures? Not just the family history, but the child himself has actually had a previous febrile seizure. Okay. I'm not seeing hands, not seeing new comments in the chat, which is fine. Just for people to think about the different kind of things that provokes. A few other things to think about. Well, would it be different? Well, should our approach be different if they had received a routine childhood vaccine a few days ago, and presumably or potentially the fevers from that, and not from an acute febrile illness? Does that change what we should do for them the next time they're due to receive a vaccine? And a very different scenario now, but what if they've got this fever and they're not doing well, they are critically ill in the intensive care unit? And last one, I think, at least for this slide to think about is, does it matter if our decision is to give an antipyretic, does it matter if the fever and the child's clinical condition responds to the antipyretic? Does that in some way tell us about the severity of the illness or what the potential underlying cause might be? All right, next question. And here we can pop up a poll again, if you don't mind. Thanks, Jeremy. And this is just a single answer for people to choose from. That's a patient's temperature chart, and the question is, when would have been, considering that was their fever profile, when would it have been the best time to have taken a blood culture? Option A is at the height of the fever. Option B is after the fever spike, just afterwards. Option C is just before the next spike. Or option D is it probably doesn't matter. You can do it anytime. And yeah, as I said, please do feel free to respond to that poll. We're doing well. Up to nearly 100 people have responded so far. Go for a little bit longer. Okay, Jeremy, you can close it if you like. So here the most popular response is option A. So just slightly over half of people would say it's best to take it at the height of the fever. And option D, people saying it doesn't really matter. Okay, as I say, we'll come back to all of these things. I'm very happy to see that we're still getting most of them wrong, which is outstanding. Which means that it's encouraging for me, because it means that the talk does still have some value. Okay, and as I said, the topic is a little esoteric in some respects. So here we're thinking about not so much, not just humans, but just thinking a little more broadly around how do each of these respond to infection. And again, we're talking mainly here about fever. So mammals, birds, reptiles, fish, bees, leeches, plants, how do they respond to infection? Don't know if there's anybody who wants to contribute to the discussion at this stage. Pick one of those, or if we can just give it some thought. And as I say, I'll come back to that. This I cover in some of the talk to some extent, but otherwise, anything I don't cover, we can come back to. Okay. Not seeing comments, not seeing hands, but please do think about it. And if you never thought about it before, then I definitely have stuff to teach you, because it was new information to me when I first started looking at it. And this is just a bunch of acronyms. So for people who like them, think about those, and we'll come back to that right at the end. Okay, so you guys can sit back and relax for a bit. That's most of the responses that I need from you are already in, and I'll do just a bit of talking and a bit of background to the whole condition of fever. So, as you know, the so-called 4 cardinal signs of inflammation include fever, as Kellogg on the top of that list, and were first described over 2,000 years ago by Celsius, and that's where the Celsius temperature scale that we use comes from. And the others were dollar, rubor, and tumor, so pain, redness, and swelling. But certainly an important one amongst those, and potentially the most common amongst them when inflammation occurs, is Kellogg or fever, and that's both locally at the site of inflammation and systemically, which is what we're talking about today. What is the effect of fever on the immune system? And this is a review article from 10 years ago now, and I suspect we know more about it, but probably not much more than the message I want to kind of communicate here, which is, as best as I can tell, every single part of the immune system that has been evaluated at different temperatures seems to perform better at higher temperatures. I'm not going to go through all of the pictures here, and you'll see in the next couple of slides more of the same. But there are a whole lot of heat-sensitive activities. Neutrophil function certainly seems to be improved, both with respect to neutrophil movement and neutrophil actual phagocytosis and killing activity. And the same seems to be true for NK cells, for T cells, both Th1 cells, and I think pretty much all of the others. When they've been evaluated, the function seems to be substantially better at a higher than at a normal or low temperature. And you can see some of the summarized here. And as I say, this is already 10 years old, but as best as I can tell, if anything, the message is even stronger, that our immune system is certainly quite happy to work at a higher temperature than normal physiological body temperature. And then we should be asking ourselves, well, if the function is better, then should we be treating fever, and is there potentially any harm from treating fever? So if I'm hoping to really got you thinking along the lines that fever is almost certainly beneficial. So are there potential harms to the organism from mounting a fever? And the obvious one is that every 1 degree elevation in our core body temperature requires a substantial, at least 10% and potentially greater than 10% increase in our metabolic rate. So if we start putting, if we start increasing our core body temperature by 3 and 4 degrees, that's potentially almost a 50% increase in our metabolic rate, which is a substantial increase in the amount of energy required. If kind of linking to what I said before, if fever is good for us, is there any reason to think that treating fever may be harmful? And going back to when antibiotics first became available, so a long time ago, initial observations were actually exactly in line with that. There seemed to be, while these were not by today's standard high quality studies, but the best available evidence at that point in time, largely retrospective, did seem to suggest that there was an increased influenza-related mortality in people who received antipyretics. And I'll show you some of these studies now, and the evidence is somewhat conflicting, but the initial evidence did suggest that there was an increased mortality in ICU patients who were febrile and received antipyretics. And this I just like because, I don't know, maybe it's me just being a little bit weird, but rabbits who had rinderpest, which is now no longer a concern, it's one of the few diseases that has been eradicated from the planet as far as anyone can tell. The rabbits who had their fever treated, sorry, no, I think this was the rabbits who mounted a fever response had a much lower mortality than those that didn't. I might be wrong about that. I'm not sure it was whether they had the antipyretics and had the high mortality, but certainly those who had a fever and were allowed to and that process wasn't kind of interfered with pharmacologically at the lowest mortality. Looking back into kind of evolutionary time, what we see is something I found really quite fascinating. And when we're talking about both cold and warm-blooded animals, what we see is that our last common ancestor between cold and warm-blooded animals was probably about 600 million years ago. However, it appears that the pathways that warm-blooded animals use to mount a fever started to evolve as much as 2.5 billion years ago. So long before we were warm-blooded, we were already starting to evolve mechanisms that are still conserved to this day to try to impact on both the inflammatory response and, in all likelihood, because of the degree of evolutionary conservation, improve outcomes. So some of the heat affected aspects of the immune response started emerging about 2.5 billion years ago, and that preceded emergence of innate immunity and preceded by a long way emergence of our adaptive immune response. So it certainly seems to be one of the very, very first aspects that both cold and warm-blooded animals evolved to combat infection. And because I say this precedes even the last common ancestor of cold and warm-blooded adults, precedes potentially even the development of kind of organized multicellular organisms. And I'm just going to touch on some examples of this, those that I found interesting, and I hope you do too. So if you look at some cold-blooded animals, starting with reptiles, iguanas will normally, when they have an infection, will engage in a changed behavior that allows their internal core body temperature to increase. And if from an experimental point of view, they're not allowed to engage in those behaviors, so they're not allowed to go out and spend more time in the sun, potentially being more exposed and increasing the risk of being spotted by a predator. If they're not allowed to do that, they have a 75% greater mortality. So if they're confined to an area where they can't increase their core body temperature, they're more likely to die from infection. Fish, very, very much similar sort of behavior. And I'll show you what one of the graphs from one of our studies in a subsequent slide. But fish actually will leave the safety of the deeper water to leave the safety of, for example, corals and plants and things like that, where they're normally in, and actually ascend to warmer water when they have an infection. So this does raise their core body temperature, but in all likelihood also increases the risk of being spotted by a predator and being eaten. But despite that, they will continue to behave in that sort of behavior. And I'll show you what happens on that slide if we interfere with their ability to do so. Insects, and if there's one fact around the whole of fever in this talk that I find so incredible, really is what bees do when some of the members of a hive have an infection. So they, much like ants, are the prototypical social species, and so if only some of the members of the hive are unwell, the entire hive increases the internal temperature of the hive in an effort to try and improve the recovery and the well-being of those that are experiencing the infection. And it does seem to do so. They do seem to do better. And the question is, well, how do bees increase the temperature of their hive? And as I say, this for me is one of the most fascinating things, is they engage their wing muscles, but they have an ability to disconnect the wing muscles from the wings themselves. So normally contraction of those muscles would increase the temperature of the muscles, but would also cause the wings to flap, which may well actually cause dissipation of heat rather than retention of heat. But by disconnecting the activity of the muscles from the wings themselves, they contract those muscles, generate the heat, but without moving their wings. And I suppose the equivalent to the core temperature of the hive increases as a result. and that seems to confer health benefits to those that are experiencing infection. And even more interesting, and this applies to all of the examples I've come across, was that if these animals are treated with antipyretics, they then no longer behave in or engage in the heat-seeking behavior to the same extent as they would have done in the absence of the antipyretics. So the antipyretics are able to inhibit the heat-seeking behavior of these cold-blooded animals. I'm suggesting that that pathway, as I was kind of touching on before, that's been so well conserved from an evolutionary point of view, is along the same lines of where our current pharmacological agents are active. I said I'll show you a couple examples of this. So this is the one of the desert iguana studies, and you can see here that if the temperature that they're able to get their core body temperature up to is high, very, very high survival rates. Whereas if you don't allow them to do that, and their core temperature isn't allowed to go above 34 degrees, at least in this example, 100% mortality within about 3 days after being exposed to a parenteral infection. Very, very similar thing with goldfish. So if they're kept in a setting where they are not able to seek out warmer water, very, very much high mortality at the lower temperatures than if they are allowed to engage in activities to reach a high core temperature. I did touch on plants, and they, again, it seems using at least to some extent the same metabolic pathways, also increase their temperature in response to infection. And they do this predominantly by increasing the leaf temperature. And the way to do that, because they obviously, compared to the other animals we've been talking about so far, can't move to warmer areas, they can't contract muscles the same way, for example, I was mentioning the bees do. So what they seem to be able to do is they're, to a greater or less extent, are able to mediate their mitochondrial respiration, I think, if I remember correctly, largely through uncoupling oxidative phosphorylation to some extent, so that they actually end up producing more heat than usable energy in order to get their leaf temperature upwards. And also, not surprisingly, will move their leaves as they normally would to follow the sun, but to an even greater extent to increase the temperature. So we've kind of started talking about, well, what is the effect of the higher temperature on the organism experiencing the infection? So now just to flip around to some extent, well, what is the effect of higher temperatures on pathogens? I've just given a few examples here, there are lots more. So to start with poliovirus, so poliovirus is found to have a more than 200 times reduction in its intracellular replication rate at temperatures of 40 to 41 degrees. So much less able to replicate. Variety of gram-negative bacteria were evaluated, and serum-induced lysis was substantially greater at higher temperatures. Pneumococci have for a long time been shown to exhibit lower growth in the CSF in the presence of fever. The causative organisms of syphilis, leprosy, and malaria are all able to grow much more slower at higher temperatures. And there was one review that I found that looked at 432 strains of bacteria and their activity of 17 different antimicrobials against those strains, and to compare the effects at varying temperatures. And across the board, there was greater activity of antimicrobials at the higher temperature, and conversely, understandably, lower MRCs were measured at those higher temperatures. And this does link to one of the scenarios that are laid out by us earlier on. There doesn't appear to be any difference in the immunogenicity or the adverse effects from vaccines when routine childhood vaccines are given during febrile illnesses. We know that vaccination coverage rates for routine childhood vaccines are not where they should be. And I suspect your experience is likely similar to mine, that we see well-meaning healthcare providers deferring vaccines because a child is a little bit unwell and may have a mild fever. And that certainly doesn't seem to be the best practice at this stage. Continue to look at the effects of antipyretics and looking at respiratory viruses. It's been shown that longer shedding and suppression of neutralizing antibody response can be found when those patients are given antipyretics. If you look at malaria, and this is largely untreated malaria, but patients who, or at least I think animal studies where, can't be separate. I think I may have it slightly wrong, but certainly there were concerns that p-falciparum parasite clearance was delayed in the context of exposure to antipyretics. Patients with salmonella gastroenteritis showed prolonged excretion if given antipyretics, and children who are given paracetamol as an antipyretic before being vaccinated, it can be shown that the immune response to the vaccine is attenuated. So that's why it is not recommended, even pretty much in anybody, to be given the antipyretic prior to being vaccinated. Post-vaccination, once they develop the vaccination-related fever, that might be a very different story, in which case, because they've already mounted their immune response, and part of that is what you're seeing in the fever, the use of antibiotics in that context probably isn't going to markedly affect their immune response. And varicella, it's been shown that varicella lesions resolve slower in people who get antibiotics. So hopefully I'm starting to convince you that fever is good for us. It doesn't make us feel great, but it nevertheless is something good, and that treating it may not always have optimal outcomes. So are there times when fever is bad? And I've listed some examples here, and you'll see that I have put fever in inverted commas there because these are conditions where the elevated body temperature is probably not what we would consider a true fever. So a true fever is where through increased generation of heat, through reduced heat loss, through changes in our behavior, we elevate our core body temperature and we protect that higher temperature. So efforts made to try and bring that down will result in increased efforts to try and conserve that or preserve the higher so-called set points. So what we're talking about here, these are a number of conditions, and there are others where a higher temperature has been associated with worse outcomes. But all of these probably relate more to the degree of tissue damage and possibly the loss of the autoregulation that is important. And it's those aspects that are probably important to consider when understanding the higher risk of worse outcomes. And these are situations where antibiotics are unlikely to result in much change because it's a very, very different pathway. But where high temperatures are associated with worse outcomes. And this is a new slide that I thought I had to bring in considering what else is going on in the world at the moment. And you can see there are no inverted commas around fever there. That's in the context of pregnancy. So untreated fever in pregnancy has been associated with increased risk of miscarriages, has been associated with birth defects affecting face, spine, and heart predominantly. And interestingly enough, potentially an increased risk of autism and other psychiatric disorders, possibly schizophrenia. So the whole discussion that's going on now, particularly emanating from the US around the role of antibiotics in pregnancy and the potential harm from what's being recommended there at this stage. And relates to this, is that recommending avoiding treating fever in pregnancy may well result in far worse outcomes and no real increased risk in autism in those children, potentially even an increase. And so it's a particularly difficult area because we don't really have alternatives when the decision is made to treat fever in a pregnant person, because non-steroidal anti-inflammatories have been linked to adverse outcomes in and of themselves. And this is just, I just put the title there of the article from a couple of weeks ago from Nature. People want to kind of look into it a little more detail. All right, so carrying on with potential adverse effects of antipyretics, paracetamol, which is the one that most people wanted to use in the scenarios I outlined. We know that paracetamol itself is dangerous in overdose. Not to the same extent, but to some extent may also inhibit platelet function when you're considering. I mean, obviously, non-steroidals will do so to a greater extent, but paracetamol potentially also does have some adverse effects on cardiovascular function. Interestingly, is definitely associated with asthma, with being diagnosed with asthma in young children, but potentially may even be more than just correlative, may actually be causative in that pathway, although that's still an emerging field of investigation. And as I say, has not been reliably linked to increased risk of autism in anybody. Non-steroidals, everyone I suspect on the call knows, lots of adverse effects, particularly when used for long periods of time in high doses, including platelet, renal, and GIT effects. If you remember back to the responses to the poll, that third question, the 1-year-old child with a high-grade fever, half of the people in the audience indicated that tepid sponging would be part of their approach to that child. And we've known for a very long time that that's not helpful. And if you stop and think about it, it makes sense, because what you're essentially doing there is you're cooling the child's periphery and limiting their ability, and therefore the child's response is going to be to try and elevate their temperature further, to try and bring up the temperature in the areas that we've now cooled. And what ends up often happening in that sort of context is that the core temperature goes up even higher than it was before the tepid sponging was done. Sympathetic activity goes up, vasoconstriction occurs because of the exposure to the cold, shivering may happen. All of those will actually increase oxygen consumption further. So it's entirely inappropriate in any sort of context where you think the elevated temperature is from fever, not something else, to be considering tepid sponging. And it's been discouraged for a long, long time, with one maybe small exception. And that's where the decision has already been taken to give antipyretics, so that essentially that set point has already been reduced. And in that context, you could argue that the physical methods may hasten the body's ability to kind of get back down to the now lower set point. So I think there's some logic behind that. So if you're going to use physical methods, you certainly wouldn't use them in the absence of antipyretics. You probably don't need to use them with antipyretics, but if you really wanted to make an argument, and I don't think it's a strong argument at all for what role they may still have, it's after giving the antipyretics. I did touch on this a little bit earlier, just around the effect of antipyretic use on influenza, and at a population level, mathematical modeling suggests that the greater the use of the antipyretics in the population, the greater the burden of influenza in that population, probably by increased duration of shedding viable virus. Just coming on to the issue of the use of antipyretics in the critical care setting. And so this is just one of lots and lots of studies. This looked at a meta-regression analysis looking at over 10,000 patients, and fairly strong suggestion that where those that are able to mount a fever have a reduced mortality, whereas those that aren't, and that includes those where it's pharmacologically treated fevers, there may be a high mortality in septic patients. This is one example of one of those studies, and you can see here that at least in this one, a suggestion that quite substantially higher mortality in those where fevers are treated aggressively. And that question was largely unanswered until this NEJM study from about 10 years ago now, which specifically looked at the use of paracetamol, acetaminophen in critically ill patients with suspected infection. And reassuringly, when modern ICU techniques are being used, the impact of treating or not treating fever pretty much falls away completely. So absolutely no suggestion of a difference here. And this does seem to be the highest quality evidence that that is available even now, 10 years after it was published, suggesting that while there were initial concerns about potential harms of treating fever in the ICU setting, there doesn't seem to be any benefits to treating fever, but at least the risk of death doesn't seem to be substantially different. This has been evaluated further in a systematic review, which did include that study. I looked for a more recent one. This is, I think, a 2017 systematic review, but it essentially found the same thing, that there was probably no benefit nor any harm to treating fever in the modern ICU setting, considering all the other interventions that are being applied. Okay, so now little more humor, I suppose. If I'm hopefully getting close to convincing many in the audience that we have been overusing antipyretics, but we know that fever is often associated with pain and doesn't make us feel very good. If I'm saying to you, maybe be a little more circumspect with use of antibiotics, well, then what? So if you start looking on the internet, you'll come across things like this. So apparently, you can reduce high fever in a few minutes with some eggs. But what about our vegan colleagues who won't eat the eggs? Well, you'll find very similar recommendations for them around what can be used to reduce fever using natural products. And there are a whole lot of them out there. And this is just two examples. And you can see here that some interesting recommendations and almost no overlap. The only one recommended by both of these sites that appears on both these lists is basil. I'm going to go through the last few relatively quickly because I see we are a little running out of time. This is an important topic, and it does come up often. Febrile seizures in children are common and probably deserve a full talk themselves, because we see that very, very commonly they are mismanaged. But I have put this in here, and again, it's a 10-year-old reference, but it is still, I think, one of the best short 5 or 6 page articles around an approach to febrile seizures and an improved understanding. And the important things here, and I think I do come across it, cover it a little bit later, is that antibiotics do not make one bit of difference to preventing febrile seizures in children who've never had them, in children who've had them before in previous febrile illnesses, and in children who've had them with their current febrile illness. Antibiotics, unfortunately, I suppose to some extent, because it would be nice to know that they had some benefit along those lines, don't do that. That's not to say we shouldn't be using them. They absolutely do have a role. All of us know how horrible you feel when you have a fever, and if the antibiotic is going to relieve some of the symptoms, well, then that's not a bad thing at all. But certainly they should not be used with the intention of reducing febrile seizures, because they just don't do that. And one of the other recommendations from this review article is exactly what I've been saying earlier around the role of tepid sponging, which is not recommended, hasn't been recommended for a long period of time. Children should not be underdressed or overdressed, and antibiotics should be used to relieve the distress of feeling unwell, but the prophylactic use does not reduce recurrence risk. Also an old article, but it's another one that I would recommend people having a look at, because what this, again, short article does is it basically asks many of the questions that we or our parents of our patients would ask about. Is fever dangerous in itself? The short answer to that is no. Is a child with a high fever more likely to have a serious underlying cause? And that links to one of the questions I posed earlier. Certainly in the older child, no. The height of the fever doesn't seem to have much relationship to the severity of the underlying cause. That may not be true in young children, particularly infants, where there is some correlation, although not all that strong, between higher fever and more serious causes. What are the benefits of trying to reduce a child's fever? They're the same as trying to reduce an adult's fever, simply to make them feel better. There is no other reason. Should we try to reduce a child's temperature at all? And the answer to that is we can, but the sole intention of doing that is to make them feel better. And beyond that, there's absolutely no harm to be gained, and beyond the short-term benefits, probably no other real benefits. Are physical methods of cooling effective? No. Are antibiotic drugs effective? The answer to that is yes, if you want to treat the thermometer. And if so, which one should we use? And the answer to that is it probably doesn't matter. Paracetamol and ibuprofen are probably equally effective. The combination is more effective at reducing pain, but is and may be more effective at reducing the temperature. But again, that should no longer be an important thing. We're trying to do is simply to reduce temperature. Are they safe? And the answer to that is used appropriately. They are. Are 2 agents better than 1? Again, it depends what you're looking at. If your outcome of interest is anything clinically meaningful, the answer to that would be no. And there you can just kind of see the summary from that paper, which is largely what I've been saying. Okay, so if I haven't answered your questions, or my own questions, let's just go through all of those quickly as we end off. So yes, either paracetamol or ibuprofen is reasonable to treat fever-related symptoms, but the question is, are they really necessary? To avoid combination antibiotics purely for their effect on temperature, because although they will more effectively reduce the temperature, hopefully now that isn't something we actually think is important to do. But please don't feel that you can't combine them if your intention is to reduce pain, because they certainly are more effective than either of them used alone for many sort of pain-related symptoms. There's absolutely no role for tepid sponging. The height of the fever and the response to antibiotics, and I didn't cover the data behind this, but it is available. The response by antibiotics is of little informative value. Blood culture, and I'll show you in the next slide here, is highest just before the next fever starts. Now, obviously, it's interesting to know that, but you don't know when the next fever is going to be. And that relates because there's a lag between the release of the pyrogens and the fever actually coming up. But there's definitely no need to wait for fever before collecting the blood cultures. So in that slide, and I think I'll come back to it. The answer to the question is C. But should you delay taking blood cultures for a fever? The answer to that is no. And so practically D would be the most appropriate response. The best predictor of a positive blood culture is probably Raugours, and that also links to what I'm saying about the release of the pyrogens, both endogenous and exogenous, that stimulate the whole process of developing a fever, and that probably often includes Raugours, and so therefore that may well be the best time to take the blood cultures when your patient has Raugours, rather than even looking at their temperature chart. Where are we now? Fever should generally not be used as a reason to defer routine vaccines, and this I've just added on the end here, and this was added on today because we still see that this isn't the case. All facilities where patients are accessing care should start routine vaccines, as every healthcare encounter is a potential vaccination visit. This is an experimental example of what I'm saying about the optimal yield of blood cultures. You can see that optimal yield here is a couple of hours before the fever actually starts. I know I'm running out of time, so the last little bit I'll go through quickly. Some last final fun fever facts. Apparently, the ancient Romans would trim the fingernail, their children's fingernails, with the view that that would relieve the childhood fevers. And it gets a little more bizarre than even that, is that the thinking was that if you fixed those clippings to the neighbor's door with wax, that could potentially transmit the fever to them too. And I asked you what were all of those, and I'm not expecting answers. Those are the acronyms that go with a whole lot of the periodic fever syndromes. So the top 3 people may well have heard of, but there are a whole lot more that go with it. And for those of us that are still interested in the topic and would still like to learn a little bit more about it, these QR codes should take you to some interesting other things that relate to the same topic. Particularly the Curious Clinicians podcast episode on fever, I think many people will enjoy, and the Paul Offit YouTube video around if doctors was right, treating fever is a bad idea. I think those are useful, kind of, really fun things to listen to. And I think that's it from me. There was a video at the end, but I think rather let's leave that. I'm happy to take questions and comments.
Cool. Thanks so much, Gary. Really nice. A lot of people have said in the chat and on messages that you've overturned everything. The quote is, "This just challenged everything I thought I knew." So that's always a good outcome of a talk. Um, and then, yeah, so I guess I'll try and summarize a bunch of the questions which have come through in various sources and that. So with the ICU study that you showed, where they didn't, fortunately, with sort of modern ICU practices, didn't appear to be much harm, at least, although, presumably not a huge amount of benefit either. Is there similarly high quality evidence for harm in outside of an ICU, sort of in a hospitalized patient or in a sort of, let's call it a GP practice or sort of outpatient buildings? I mean, I think you made a very persuasive case that this is an adaptive response usually, but could it be similar where sort of modern techniques and antibiotics sort of obliterate any of the harm of treating it?
I expect that's probably true, and that's why I think one of the take-home messages really is that if you're going to use an antibiotic in anybody, it's probably the same reason any of us would take an antibiotic, is just to feel better. So if you think the benefit of relieving some of the fever-related symptoms outweighs the probably small risk of harms from the medication and from not having the fever, I think it's reasonable to go ahead and do it. But the idea, and again, I'm sure many people have had this experience where you see patients being woken up at 2, 3 o'clock in the morning because they were happily sleeping through their fever. But again, some well-meaning healthcare provider woke them up to give them antibiotic. Hopefully, we can kind of move towards that not being the situation. But so in answer to your question, I think it's reasonable to use antibiotics, but really the goal is to relieve the symptoms, nothing more than that. And the harm for mild infections is probably fairly minimal.
Yeah, no, point well made. And then someone's asking about whether immunocompromised, such as the neutropenic people who have made neutropenic fever or other immunocompromised groups, is there anything different about them to the sort of central message, or do we not have any evidence of that?
I haven't looked for it, so I'm open to correction if people have looked at that and can correct what I'm going to say, but I'm not aware that it's, and I can't think of why it would be substantially different. Obviously, the causes of neutropenic sepsis or neutropenic fever are different, and the clinical approach would be very different regarding investigation and management, but the likelihood of either treating or not treating fevers being greater or lesser, I doubt they'd be different. For me, I suppose the recommendation would be the same if you're going to treat it to relieve symptoms and for no other reason.
Yeah, yeah. And then, sorry, I'm just trying to catch all the questions in the chat. Then Shiva was asking about antibiotics. We know that some antibiotics have anti-inflammatory properties, such as macrolides. Are there any clinically relevant instances where antibiotics may have pro-inflammatory effects?
So no,
Yeah,
I'm not sure if anyone else does. I can't, not that I've come across. I mean, certainly the second part of that relates to causing a spiking fever. So I mean, we know drug fevers are real, but uncommon. So I mean that's possible, but they're fairly uncommon. But whether the antibiotics themselves have a direct pro-inflammatory effect over and above the effect on the organisms and the breakdown products of the organisms, I don't know. Not that I've heard, but that doesn't mean that they don't.
I think that's most of it. I guess, yeah, and I think just, I mean, to sort of to come back to, your really nice placing of this whole phenomenon in a sort of evolutionary context and throughout the animal kingdom. I mean, I remember reading somewhere years ago that it takes just a single gene mutation to knock out fever. That effectively, I think it was an IL-6 cytokine, that they were able to effectively induce this in mice so that they were unable to raise, any temperature ever. And it just, I mean, it really speaks to the point that if this was an evolutionary bad idea over evolutionary time and on average, and, with all the riders that this may not apply in the modern world, evolution would have gotten rid of it long ago. I mean, it's literally just a single mutation. That mutation, if it was beneficial, would have spread very quickly through the populations. I mean, it's clearly something, as you say,
And it's been incredibly well preserved over evolutionary time, and initially didn't actually, in all likelihood, it actually include the whole fever, because this was before there were warm-blooded animals at all. It's kind of been incorporated into warm-blooded animal physiology over more recent time when it initially evolved.
Yeah, and just to end off, see, Brahman LaRue's mentioned the wonderful adaptation about saying, "Don't just do something, stand there," which is perhaps a good lesson in general in medicine sometimes.
Yeah, great.
Last late breaking questions. What about the Darish-Herxheimer reaction when treating syphilis with penicillin? I think, yeah, in terms of I guess
I mean,
saying, would you treat it with?
Is the question, should we treat that with an antipyretic? I don't know for me that it would be any different to any other sort of setting. If you feel it's going to make your patient feel better, then give the antibiotic. If you don't think it's going to make them, or they can, the fever-related symptoms aren't too bad, yeah, don't worry.
Perfect. Thank you very much, Gary. That's really, really awesome. I think you've changed a lot of people's minds today, I hope. And really well argued and some really fascinating stuff. I really enjoyed the anecdotes from other animals too, which just plugs us into the rest of the world. So thank you very much.